Professor Nihal Thomas. He is a senior professor in Department of Endocrinology, Christian Medical College, Vellore. Sir is the principal coordinator of ICMR Collaborating Center of Excellence for Diabetes. He is currently the head of Center for Stem Cell Research. He is also the co-chairperson of International Diabetes Federation Task Force for Type 5 Diabetes. Formerly, he was the Vice Principal Research and Associate Director and Head of the Department at CMC Vellore. He has published more than 400 PubMed indexed publications. His Google citation index is 73,000 plus. His areas of interest involve the pathogenesis of diabetes in India. He has given more than 30 orations, including MS Ahuja, Subhash Mukherjee, South Asian Federation of Endocrinology, East African Diabetes Society, and he has generated about $9 million in research grants. He has been bestowed with many prestigious awards. To list a few: Lud Edenapalli Award for Outstanding Researcher in 2009, Best Undergraduate Teacher Award for the year 2023. Under his leadership, the department was recognized by the BMJ for Diabetology Team of the Year in 2015, and the Royal College of Physicians Award for Excellence in Teaching and Training in the year of 2017. So Sir will be talking on diabetes in the young and South Asia, the pathogenesis, differentials, and the road to type 5 diabetes. Over to you, sir.
Thank you, and it's a real privilege actually being over here. I feel not like a fish out of water, I feel like a blue whale out of water, because everyone talking at a cellular level, at a subcellular level, and I'm talking essentially outside the cells. So this is going to be from the micro talk to the mega talk. And basically when we think of young diabetes, these are the conditions which should come to mind when we see people who are young and lean with diabetes. These are the 7 differential diagnoses that we should be thinking about. And that's where my ideas actually have come over the years. So I'll be talking about a little bit about the epidemiology, something about the differential diagnosis, undernutrition, and the road to what we call today type 5 diabetes, and a bit of a summary of what's actually happening. So there has been a cohort which was started by a visionary biostatistician over here, Dr. Sundarrao, in 1970, called the Vellore birth cohort. And it generates good data in terms of incidence of diabetes. This is a 2014 showing you the huge prevalence of diabetes at the age of 44. So at the age of 44, huge prevalence of diabetes both in urban and rural areas, and both in men and women, and telling you that therefore a lot of people have diabetes at a very young age. Way back 15 years ago, we showed that in schools in Vellore, between the age of 14 and 17, 20% had pre-diabetes, and a very strong relationship between the waist circumference of the mother with that of the child, and the other indices of the metabolic syndrome. We also, when we did education programs across the country, we coordinated mission hospitals, and we found that there was a high prevalence of diabetes in the Northeast. This is long before Indab in 2007, 9% in Tripura, 5% in Arunachal Pradesh. But a good number of these people actually had a very low BMI of less than 18.5. And that's when we actually started thinking, is this really type 2 diabetes? What people used to call lean type 2 diabetes, but really speaking, why should we call it type 2 diabetes? So some definitions, we shall stick to young being less than 30 years and lean being according to a Lancet cutoff of 19.2, but of course the WHO cutoff is 18.5 for undernutrition. But this can be very different depending on various populations. When we say young, we have to be a little careful. This is young. This is me as a medical student at the age of 18.5 years with a BMI of 18.5. I did not have undernutrition, but I think my protein in my diet in men's hostel was not that great. So this is work generated by our team from the community health department, showing you that in Chad, which is just behind over here, 5% in the rural area have a BMI less than 18.5 in a rural area in India. But we are supposedly a higher GDP state, and therefore we may be better off than other parts of the country. So I'm coming back to the differentials, and I'm going to highlight what we think the green ones are the more common, and the blue ones as possibly not that common, maybe what we would say occasional, and then I'll come to type 5 diabetes as well. So this is how we investigate patients, take a detailed history, physical examination, and then we do certain biochemical tests. The initial part That is really, really important. The initial clinical screening is so important. The antibodies to rule out type 1 diabetes, which will be present in early type 1 in about 85%. Body composition to look at regional body fat and total body fat, imaging of the pancreas, and then of course the genetic testing, which all of you are so familiar with. So one condition which is very often missed by clinicians simply because they don't take a scan of the abdomen, an ultrasound or a CT, is fibrocalculous pancreatic diabetes. Thought to be very common at one time in Kerala. Prevalence has dropped, but is still seen all over the country right now. Some unknown environmental factor, and we still don't know what that is, with the 30% segregation and association with the SPINK1 variant mutation. Low C-peptides. As you can see, pancreas shrunken with calcification, duct dilatation, extra, and it's found largely in tropical parts of the world, in Africa, Asia, South America as well. This is from SDPGI. Young diabetics, there are 15% for fibrocalcific pancreatic diabetes. We did the genetic testing to rule out monogenic disorders at that time. We also found some other peculiarities. They had a very high energy expenditure when we did indirect calorimetry over here. And later on, we actually found, despite the alpha cell insufficiency, that they had high glucagon levels, which were driving mitochondrial activity, causing this energy expenditure to be increased. These are studies. We found a very high prevalence of hypoglycemia unawareness. Their autonomic systems were switched off in about 60% from another study. But what we found is there was an association between glucagon, and in fact in early FCPD, despite the destroyed pancreas, destroyed alpha cells, glucagon was actually elevated and was preventing them from hypoglycemia unawareness in early disease. And why does this happen? And the paradox is, in these patients, they actually have high glucagon levels which parallel the GLP-1 and the oxynomodulin levels from the L cells. So the L cells actually starting to produce glucagon. This is shown in dogs which are totally pancreatectomized, that the L cells start producing not only more incretins but also more glucagon, and therefore might drive this whole system. So these are some of the findings from our work with fibrocalcific pancreatic. I won't talk much about the clinical findings, but we have also showed that bone density and osteoporosis are more common. Autonomic dysfunction is also common. Now coming to the monogenic dysfunction disorders, not all of these are lean. In fact, most of them have BMIs more than 23, interestingly. But there is a proportion which are lean. With, I think Aaron talked a little bit about the work which we have done in the endocrine lab, and he spearheaded this, and that certain variants are more common in our Indian population. Using NGS, we have characterized the disease. These are some examples of patients, young patients with young onset diabetes, HNF1 beta with the renal cysts, and a young patient with hypoglycemia needing only diet, HNF, a glucokinase mutation, and a 2-year-old baby with diabetes. You don't get type 1 at this age. And this is a novel, this is a de novo variant of KCNJ mutation, and they respond very well to high doses of sulfonylureas. We also found that lean women, BMIs of less than 21, had in pregnancy in the first trimester had diabetes. And why? Why should they have diabetes if they are so lean? At very young ages, less than 25. And a good number of them had variants which suggested that they had beta cell dysfunction, which was inherited. And this is in local patients. A little bit of a referral bias towards the hospital, but this is exactly what we found. So our variants which we see in our Indian population are different from the West. We have a lot more ABCC8 variants. We have a lot more, we have a lot less glucokinase variants in addition. And this is important because the type of treatment, the dosing of sulfonylureas can depend on the type of MODY that you have. Here's another example, young lady with amenorrhea, bicornate uterus with an obstructed cervix, a congenital deformity, MODY 5 with an atrophic pancreas. Here's another example of a patient with an atrophic pancreas replaced. The black area is replaced with fat, steatorrhea, and of course now Sneha has actually got a large series of patients with cystic fibrosis with young onset diabetes, a condition which is thought to be very rare in India. 43-year-old nurse came with recurrent episodes of abdominal pain, acute pancreatitis, became chronic pancreatitis with the calcification that you can see, an atrophic pancreas. Later on, the child developed headaches, came with the muscle weakness. You can see the blooming in the globus pallidus, and then subsequently a diagnosis of mitochondrial diabetes was made in this particular patient. So those are some of the differentials. We have a pancreatic panel which Aaron has worked out to look for patients who have small pancreas, so it's not all fibrocalcic pancreatic diabetes. You can have another number of other variants which can cause this condition, and this is the unpublished data which shows you the pancreatic variants and young onset diabetes. Coming to lipodystrophy, a rare condition, autosomal recessive. In our screening across the board, we haven't been able to actually find many patients like this, but these are lean patients with very low total body fat. You can see the DEXA on the right hand side, and you can also see that it's less than 20%. Somebody like me without diabetes, I have a percentage body fat around 22% right now. If I had diabetes and I was a male, it will be more than 25%. If I was a female, more than 35%. So this is really low for someone who has diabetes and has insulin resistance, not deficiency. And you can see the triglycerides are high because of the abnormal functioning of lipoprotein lipase here. And this is a laminin variant mutation which can cause partial lipodystrophy where the fat in the head, 20%, is greater than the rest of the body. And this is our integrated publication of lipodystrophy. It's actually the largest clinical series, not that large, but it's a rare disorder. So they have exquisite fatty liver, grade 4. They can get cirrhosis before the age of 30. They can have laminin mutations, and they respond to pioglitazone. You can cut down the dosage of insulin by using this as well. In addition, of course, they have hypertriglyceridemia. Wolfram's-like syndrome, another thought to be rare condition, but we think we're finding it more often now. This condition is insulin deficient. They behave just like type 1, but they don't have ketoacidosis. And the classical presentation is the dead mode syndrome, diabetes mellitus, insipidus, optic atrophy, and deafness. And you can see a patient who has hearing defect, sensorineural hearing defect with optic atrophy on the OCT over here, and an atrophied brainstem. Now, we have been finding milder cases, and this is what Harika's work has actually shown, is that if you look at the y-axis, the age, and the black dots, the diabetes comes first, the optic atrophy next, and then the sensorineural deaf. So the run-of-the-mill physician or pediatrician will just think, okay, this is type 1, and they won't know that later on this might actually happen. They won't think it's a genetic disorder. So if you have a GAD antibody, IA2 antibody, zinc transport antibody negative patient with young onset diabetes without ketoacidosis, this is one of the other differential diagnoses that you need to do. Image the pancreas, low C-peptides, then do a genetic testing, and you may find they actually have Wolfram's-like syndrome. And it's important to find this out because you can actually, there are problems with the endoplasmic reticulum over here, and you can give medications. There are clinical trials using valproate, dantrolene, ibedinone, which are not very expensive medications which can actually prevent the neurological progression, delay the progression of the disease over here. And of course, there is a lot of experimental work going on with gene therapy, etc., adeno-associated viruses, etc., in that particular condition. HIV lipodystrophy, another condition which is actually not uncommon, but the diabetes is mild. Our initial study, which is actually Asha's DNB thesis about 15 years back, showing that they have a lipodystrophic features, but they have diabetes which is mild. And then following them up over a period of 7 to 8 years, we actually found that the diabetes is non-progressive, still very mild, and they don't behave like the inherited congenital forms of lipodystrophy over here. Please note that CART over here means combination antiretroviral therapy. So that's the hazard of using abbreviations in your practice. So finally, I'll come to the effects of malnutrition, diabetes, and what we call type 5 diabetes today. So way back about 150 years ago, a guy whose name I can't pronounce, Etienne Lancero, whoever he was, actually described two conditions, diabetes majeure and diabetes gras. I think diabetes gras is basically patients who are obese and who have type 2 diabetes. The other one are lean diabetes, but what he found is they lasted for 10 to 15 years, and this is an era when there was no insulin available. So they obviously were not type 1 diabetes. They might have actually been undernutrition and diabetes. Characterized in 1955 by Jones from United Kingdom and on sabbatical in Jamaica, and was called J-type diabetes, and therefore many other countries started reporting it. Got onto the WHO classification. Jasprit Bajaj was the head of medicine in AIMS, pushed it onto the WHO, but eventually with poor recognition, poor physiological, no good physiological studies, it was taken off the classification in the year 1999. So this is basically the spread of the disorder across the world, and the WHO actually drew up a map, but they also said that malnutrition causes both fibrocalcic pancreatic diabetes and this malnutrition associated protein deficient diabetes. We know that fibrocalculous pancreatic diabetes is not primarily a malnutrition related disorder, so that's not true. But then look at again the tropical spread of the disease. So we also have evidence to show that iniquity, undernutrition may actually be responsible for a lot of metabolic conditions. I'll talk about the Barker hypothesis. So if you're born low birth weight, your risk of developing diabetes, hypertension and obesity and insulin resistance is greater 30 years later. This is due to epigenetic effect in the uterus, and thereafter if you subsequently consume excessive amounts of calories, you will end up with hypertension, diabetes and obesity. Now this is very well known and it's now established, it's more than just a hypothesis. This is the Dutch hunger winter. In women in pregnancy who exposed to only 400 calories of food per day developed, their babies developed a greater prevalence of obesity and hypertension and diabetes later on. Undernutrition is still a problem in India, about 15% of our population. There is stunting, you ask our pediatricians, and low birth weight, we are the highest prevalence in the world. So I did this study about 15 years ago in collaboration with the University of Copenhagen, and we took normal birth weight versus low birth weight individuals, did in clamps, hyperinsulinic clamps, look at sensitivity, energy expenditure, and NMR spectroscopy to look at the fat in the liver and muscle. And what we found is the low birth weight people were shorter, lighter, had reduced muscle mass, increased diastolic blood pressure, and they also were habituated in taking a very low protein diet, even though protein was adequately available. Now, what we found here is also they did not have insulin resistance. That is only because their percentage body fat was low at that time. The NMR spectroscopy showed micro quantities of the fat in the liver were very low. 20% of them actually did not have any fat in the liver at all, and that's a very unique feature of the South Asian phenotype in those who have intrauterine undernutrition. So we'll now switch to children, and we know about marasmus and kwashiorkor. Kwashiorkor is still seen in countries like India, and now undernutrition, what Michael Boyne in Jamaica actually showed is that those who have low birth weight, those who have marasmus invariably have a history of underlying low birth weight in the past. So the two are associated. And when he did glucose challenge tests to children with marasmus, he found that the insulin levels were lower and that they had a tendency for glucose intolerance, indicating beta cell dysfunction in marasmic children. This is something you'll connect to very well. What has been shown over here in animal studies is that the transcription factors which may be responsible for beta cell insufficiency in rats with undernutrition, and even incretin release is reduced in rats with undernutrition with atrophy of the intestinal villi. Almost 45 years ago, Ramesh Kadodi at All India Institute did primate studies and showed that monkeys fed with low protein diets for 6 weeks reduced insulin secretion and reduced hepatic glucose disposal. Rat studies have shown that there are microislets in mice who have undernutrition, which is chronic as well. So we have a large repository of data showing that undernutrition can actually affect beta cell function, and I have not covered the aspects that undernutrition also does not cause insulin resistance. It's associated with very good insulin sensitivity in the periphery. East Pakistan, before independence, 45 years ago, a large number of individuals were lean and had hyperglycemia with insulin deficiency. More recently, a number of publications from Africa, Ethiopia, Uganda, and from Ethiopia, Uganda, and Jamaica have shown undernutrition-related diabetes being common. This is a study which we worked with the Ugandan group and found that they were beta cell deficient, and about 2/3 of them actually had beta cell deficiency along with very low percentage body fat. So the condition has received re-recognition. We did this physiological study published about 3 years ago, wherein we took low birth weight. We took individuals who had classical lean diabetes, who had a history of malnutrition, type 2 diabetes, type 1 diabetes, lean normals, and obese normal individuals. So this study took a very long time because we did all those dynamic tests in them with informed consent over a period of time. These are the subjects we did. So we looked at insulin resistance with the hyperinsulinic euglycemic clamp, and our individuals did not have insulin resistance. Those who had undernutrition did not have insulin resistance. The mixed meal challenge, and that's the blue line there, showing that the lean diabetic patients had insulin deficiency, not as severe as the pink line, which is seen in type 1 diabetes. And the area under the curve, you can say they had hypoglycemia, once again not as severe as those with type 1 diabetes. So they are different from type 1, even though they have an insulin deficiency. And of course, we have ruled out autoimmunity and genetic causes. We did a 62 gene beta cell monogenic panel also in all of them. They also have low hepatic glucose output, much lower than any other of the other forms of diabetes. The type 2s are the black with a high hepatic glucose output, and the type 1s with higher than the malnutrition modulated diabetes. So they are different with the hepatic glucose output. This is presented at the ADA 3 or 4 years ago. And it shows that they have an incretin deficiency. You can see the IGTTs and the OGTTs that the incretin levels are flat, GLP-1 are flat in patients with undernutrition-related diabetes. So this article received attention in the Scientific American in 2023, and this was published more recently in Physiology, summarizing that they have low insulin secretion, low hepatic glucose output, low insulin resistance, low GLP-1 secretion. A very unique phenotype by probable intrauterine undernutrition coupled with postnatal undernutrition at the same time. The guidelines set out by us in January, and Dr. Ullas is also part of this group, wherein we publish this in the Lancet Global Health, basically emphasizing, there are 39 signatories to this article emphasizing the importance of this particular condition, and the features of this condition are described in this condition with low BMI, possible history of low birth weight in addition, and the other features which I described to you in addition, ruling out all other causes for diabetes. So here's a model, and Yajnik helped us with this. If you're born low birth weight and you had overnutrition postnatally, you develop type 2 diabetes. If you're born low birth weight and if you have undernutrition postnatally, you have type 5 diabetes. So you can differentiate the different conditions from one another. Type 5 has low C-peptides, type 1 very low C-peptides, monogenic in the fasting state but may respond to sulfonylureas. Lipodystrophy, the C-peptides are elevated, and the percentages of body fat in each condition are quite different. So here is some work which Gurbind and Mohan are planning to do in terms of looking at these the fibroblasts and then converting them into beta-like cells and trying to study them. And of course, I got some lovely ideas after listening to all the basic scientists in the last couple of days as to how we can try to characterize this disease and understand why this happens at a cellular level. So let me conclude and say this disorder is a distinct metabolic entity characterized by insulin deficiency, low preserved insulin sensitivity, low body fat content, and a relatively reduced hepatic glucose output. There is an antenatal and a postnatal insult. We need to understand the differential diagnosis, rule out other conditions, and of course future directions. We need a diagnostic algorithm, which we actually have, but we need to understand the basic science aspects of this disorder in greater detail. Here is a cheat sheet to use for the differential diagnosis in the other conditions. For type 1, fibrocalculus pancreatic diabetes, monogenic disorders, lipodystrophy, Wolfram's HIV lipodystrophy. Number of collaborating institutes and funding agencies over the years, and of course a large number of people whom I worked with, and of course this slide does not perhaps illustrate everybody we have worked with. Thank you for your patient listening.
I have a naive question. In the low birth weight, so what is happening there? It's an increased lipogenesis that is leading to accumulation of, leading to obesity. That's the first question. So what is physiology sensing low birth weight as? And the second one is, I'll just continue that. Second question is this, the low birth weight has also to do with the maternal or paternal malnutrition here? Is there any link, or is it inherited trait? What is the basis of it?
Good question. So the low birth weight is largely related to maternal malnutrition. It occurs in that particular generation wherein the mother has undernutrition and the child has undernutrition. Having said that, what studies from Europe extra have shown is there is some epigenetic imprinting, and usually that effect will last maybe for a couple of generations. So it is likely that the babies will continue to be low birth weight, and even our own study, which we did with the chat cohort, which I showed you where we did the clamps, there appears to be an intergenerational effect in terms of the height and the body composition between the parents, etc. So it's not totally lost. And that may be also another reason why our birth weights in India are low even right now. We are actually seeing what was, I shouldn't be using politically incorrect words, but we do know that we had a very low life expectancy 120 years ago, as low as 22 years. And we do also know that undernutrition was a huge issue in the late 1800s and the early 1900s for a lot of the population. So those effects and imprinting, epigenetic imprints will be there for a few more decades, provided we maintain this current level of nutrition. Now, mechanism-wise, we have already mentioned that they tend to accrue more fat because of the thrifty phenotype that they have. There have been various post-receptor mechanisms which have been postulated for why they have insulin resistance. They also have a GLUT4 defect, therefore their glucose uptake into the muscle is low, and their beta cell function is intrinsically low. Now, if they have underfeeding after delivery, as infants or as children, then their beta cell dysfunction gets enhanced even further. Of course, it's impossible to do these studies prospectively in human beings from an ethical perspective. Yeah.
So in the type 5, Dr. Nihal, in the type 5 diabetes, what are the levels of DPP?
We don't know. It's not been done. We have not checked that out at all.
Because is it related to satiety, and because your liver parameters are also changing? So that's why I was thinking.
We really don't know. You're asking about what are the levels of dipeptidyl peptidase?
Yes.
We don't know. We have no idea. These are every single basic science question is open over here, and I'm sure all of you are welcome to think about things, and I'm happy to work with you. You're happy to work with anyone, of course, obviously, as far as this is concerned. Thank you.
Very nice talk and very informative. So I might have missed it. So if one identifies type 5 diabetes, right, is the current therapeutic interventions are sufficient, or we have to completely rethink about a new set of interventions? What is your
deliberately left out 3 slides here because of lack of time. When we looked at that particular group of subjects where we publish in Diabetes Care, it's a small number, but there's a 50% response to insulin. But the good news is that 50% of them respond to oral anti-diabetic agents, right? And this has also been reported in the African groups where they have much larger numbers of patients per se, wherein even though they are very lean, they do respond to sulfonylureas, and some even respond to metformin for that matter as well. But it's not been systematically studied, but we do know that they respond to oral anti. When you give them insulin, they respond very rapidly, and it's very hazardous in countries, in low resource settings, when you give them insulin, they can get perilous hypoglycemia in addition, very dangerous. So that has been a major issue where they die of hypoglycemia as well. And that partly may be because maybe the hepatic glycogen, the hepatic glucose output is low. So intrinsically, because of the chronic undernutrition, the hepatic glycogen storage may be low, and therefore they cannot combat the hypoglycemia which they have. And of course, there are other vicious cycle issues. Because of the poor control, they may have autonomic dysfunction and under-recognition of hypoglycemic symptoms as well. The catecholamine secretion, etc., may be defective.